Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. We are at the 214th episode of the CodeCast podcast, and I wanted to get back to coding today. I've been talking about vaccine mandates and all the Medicare breaking news for days and days, but the CodeCast podcast was originally set up 4 years ago now. We just had an anniversary to focus on industry updates, but also coding, billing, reimbursement, compliance. I know I just did a recent one on what it is to be a medical assistant, and that was pretty popular. But what we do is code, thus the name CodeCast. So today I wanted to give you some cardiology specialty coding tips. Terry Tuesday tips, whatever you want to call them, Tip Tuesday, but we want to make sure that you've got your coding tips for different specialties. And I've done this a couple of years ago, but I want to help with your workflow and coding processes and kind of get back to that. And hopefully you're going to be taking my fourth quarter Medicare update. You can go to nschbc.org, and that will really give you all the information you need. Look for the educational opportunities, and then the quarterly update webinar. And that's going to be everything Medicare. So whatever came up with Medicare between the vaccine mandates and the Cures Act and the fee schedule, and just everything we're dealing with for the last quarter. So that you have to pay for, but this we're going to just talk about some coding today. And then because cardiology is my number one specialty, I'm going to start with cardiology. Even though I code for 8 different specialties plus some subspecialties, this specialty I've been coding for over 30 years. So I really want to just kind of get into some of the situations that you may not have thought of when it comes to coding for cardiology services. I'm going to be maybe in the Cath Lab, possibly interventions, maybe even some stress tests, but there's been a lot of questions that have come up. And I could also do this as part of a top 10 Tuesday, which I do at the last Tuesday of the month, and I may add to this next week, but today I wanted to focus on some things that have come up. So one of the things that comes up during a heart cath is how do we code for what they call an ascending aortogram. It's also called a root injection. Okay, so an aortic root injection. So if a true diagnostic abdominal aortogram or a thoracic aortogram is performed, then they have separate codes, 75625 or 75605 for the thoracic aortogram. And if you are not in your own office or in your own office-based lab, or your own cath lab, then anything that we're talking about, heart caths and the catheter-based services or anything that's a radiology code will have a 26 modifier. But extra injections, such as the ascending aortogram or root injection, these are add-on medicine codes, so that would be 93567, and it's performed during a cardiac cath, and it has to go with a heart cath code, so a 93458 or 93454 or a 93460. So the add-on code for an ascending aortogram during a heart cath is 93567, does not need a modifier, and it represents what we call a supravalvular aortography. That involves an injection of contrast into the aorta just above the aortic valve, okay? And it's imaging that ascending aorta. So for aortic insufficiency, or if there's an ascending aortic dissection or maybe an aneurysm there. But let's say you also did a diagnostic abdominal aortogram at the same time. Well, that would be 75625 with a 26 modifier. Again, if you're not also billing, if you're billing the global, then you wouldn't need that. But just remember that this is an add-on code. So, and if you are injecting that many times in the aorta, also know that's unusual because injection of dye can also trigger renal failure. So you have to just think of the entire clinical and billing and compliance aspect of that. So we just want to make sure that you're clear on what you're looking at. Also know that 93567 is not a arch injection. So if your physician injected in what we call the arch or the cervical cerebral arch, then that is actually 36221 and includes the catheter placement. Okay, so that was changed a few years back when all of the carotids, if you will, because that's considered a non-selective carotid, were changed to include catheter placement and injection. But one thing just to keep in mind, when you code for injections, whether it be an arch or root injection or a thoracic aortic injection or an abdominal aortogram, remember you're coding per injection, not per views, not for additional views. And so now if you're in the aorta and let's say that you move the catheter a couple of times for a diagnostic abdominal aortogram, you only get it once because you're in the aorta. Same with thoracic, same with the root injection, same with the arch. So just be careful with trying to code multiple injections for that. But you do get each one. But if let's say that your physician did a runoff study with an abdominal aortogram, 75630, and then they said that they moved the catheter again down to the aortic bifurcation or where the legs split off and injected again to look at the legs. You wouldn't get a second injection because you already captured the lower extremity to above the knees in the 75630. So you just have to be very cognitive of what is going on, not only with the injection procedures, but compliance, what's expected, and then also what the ACC says on some of these services as well. So I'm going to switch gears a little bit, still sticking to cardiology. This is another tip. Sometimes it comes up where a temporary pacemaker lead is inserted during a diagnostic heart cath. And I get the question a lot, is it appropriate to bill for that temporary placement because the patient doesn't leave the procedure room with it typically, or sometimes they might. Well, here's what's weird about this. So the NCCI Policy Manual for Medicare Services, Chapter 5, Section D, I always try to give you chapter verse, says CPT codes 33210 and 33211 describe insertion or replacement for temporary transvenous single or dual chamber cardiac electrodes or pacemaker catheters, respectively. And these codes shall not be reported with open or percutaneous cardiac procedures performed at the same encounter. So this bugs me. The reason it bugs me is because when we are looking at blood flow, arteries, veins, and blockages, and subtotal and total occlusions, during the heart cath, sometimes the computer of the heart will shut down, and that's called an arrhythmia or an abnormality. And to keep the patient pacing or they'll die, the doctor quickly puts in a quick temporary pacing lead. Well, that's separate. That doesn't even have anything to do with the heart cath. So why can't we get paid for that 33210 Not sure. But we're not allowed to. It actually says you can't bill for it at the same encounter. So it really doesn't make sense from a clinical perspective. So we are asking Medicare to revise that because it's apples and oranges. Doesn't make sense at all. Now, what if your doctor says in a report that they did a non-selective renal angiography during a heart cath? Do you report a 75625 or do you report a 36252 for a selective renal? Well, remember, it's non-selective renal. What that means is that the catheter is still in the aorta. Now, way back before 2014, we used to have a G code that Medicare wanted because of all the inappropriate or incorrect coding for this. But if your physician says I did a non-selective renal, it means they're doing an abdominal aortogram to visualize the renals from an aortic injection. That's the abdominal aortogram, 75625, again, 26 modifier. So just because you see the word renal, make sure you also see I selectively engaged or I selectively opacified or I put the catheter into an actual renal structure before you switch to the 36252s or 36251 codes, because that would be incorrect. All right, so we just don't want to overcode or undercode there. Now, what about the coding for a closure device? Can we code for that? No. So did you make the hole? Yes. Close the hole. Don't ask for extra money to do it. It's kind of like a doctor or a surgeon saying, I want extra money to suture up a patient after I did an appendectomy. So it even says in CPT, no part of not even the contrast, the device, nothing that closes the opening that you made should be reported. It's just inherent to the procedure. So you're not going to code for that or report that separately. Does the hospital get some kind of a code for inventory for the minks or the angioseal devices or anything like that? They only get informational reporting. They actually don't even get paid for it anymore. It's actually included in the OPPS and inpatient package. So you don't want to code for that. So let's code for an interventional scenario. Let's say that you had a patient that had a stent of the left anterior descending artery and a stent of the left circumflex artery. Well, because that's two separate arteries or vessels, you actually get to code the 92928 LC and 92928 LD. You always make sure you have your modifiers on there twice. Now, you're going to need a 59 on one of them because you're repeating the same code, and a lot of times the payer doesn't pick up the vessel modifier, even though they should. And so we don't want a duplicate claim denial. But you do get both of those services because you're in a separate vessel. The one thing you always want to keep mindful of in cardiology coding is that you code by vessel, not by intervention. So we're not necessarily coding for two stents, we're coding for two vessels that each had a stent in them. So for example, if your physician said, I placed two stents in the left anterior descending artery and 3 overlapping stents in the right coronary, you only get 2 codes. You would get 92928 RC and 92928 LD 59 because you're treating 2 vessels, not because you're placing 5 stents. So always keep that in mind, that it's per vessel, not per intervention. Otherwise, you're overcoding and they will definitely ask you for a refund, and you'll start getting in trouble if you overcode that too much. So just want to be very mindful of understanding the rules when it comes to interventional. Now, what about a patient that had a aspiration of a thrombus within a coronary vessel? So there is a code 92973, an add-on code, but this code represents a mechanical thrombectomy. And actually in the descriptor itself, it says in CPT as well, non-mechanical aspiration thrombectomy is not reported with 92973. So you would not code that at all. Only if it's a mechanical thrombectomy, typically done with an angiojet device, because they have to kind of take down everything that they're doing and reset the area for that. So just making sure that you're aware of the thrombus versus the mechanical thrombectomy versus the aspiration thrombectomy. Aspiration thrombectomy is not going to be reimbursed no matter what you try to do. So be clear on that. Otherwise, you could definitely overcode on that. Okay, one other thing I just wanted to comment on as far as a coding tip for certain services would be if you are reporting a heart cath at the same time as an intervention. So if you're reporting a stent or an angioplasty or an atherectomy at the same time as a diagnostic heart cath, and remember, the patient can't have a prior catheter-based service. This has to be diagnostic, meaning you're still looking for a problem. So let's say that you have a true left heart cath with a left ventricular injection plus coronary injection, 93458, 26 modifier, that led to a stent on the same date, same session, 92928, let's say in the left anterior descending artery, LD. Well, you're going to need on your heart cath, because that's a lower valued procedure. If it's Medicare, I would put an XU on it, modifier, after the 26. That means that it's not an overlapping service. It's a subset modifier, 59. And then if it is a commercial plan, use the 59 after the 26. It will help avoid denials, because the CPT book is pretty clear that if there's a prior catheter-based service, or if it's just what they call setup angiography, meaning the patient had a previous heart cath, but now the interventional physician is going in and injecting to be able to visualize and measure the vessel for the stent or the balloon, then that is not billable. So it has to be diagnostic. And again, that means this is the first time you're going in, doing a cath, deciding what the next step is. So you always have to keep it diagnostic, otherwise it won't be paid, and it shouldn't be paid. Okay, so let's take a look at, even though I've been doing coding questions, or I should say coding information, coding tips, let me keep that tip line open. Let me do a question on something that has to do with Medicare regulation. So I had a question that come from one of my Coding Corner clients from Maryland. Thank you. It says, Terry, I don't understand what the acronym MUE means in relation to the CMS services. What does that stand for? Okay, so Medicare, CMS is the Center for Medicare and Medicaid Services. What MUEs are, it stands for medically unlikely edits. So specifically, Medicare says an MUE is a unit of service edit for a healthcare common procedural coding system or current procedural coding system. So a HCPCS code or a CPT code. And this is for services rendered by a single provider supplier to a single beneficiary on the same date of service. So the ideal MUE, or again, medically unlikely edit, is the maximum number of units of a service that would be reported for these CPT codes. So on the vast majority of services reported, sometimes certain line items get, a ton of duplication or a ton of units. And what they're saying is this is how many units are likely to be billed. And so they came up with this MUE kind of scenario because they're adjudicated either as a claim line edit or a date of service edit. And the program was developed to reduce the paid claim error rate for Medicare claims, specifically surrounding clerical entries or errors due to anatomy, code descriptors, coding instructions, policies, even prescribing information when certain claims data was reported incorrectly. So, for example, this one comes up all the time. How many MUEs, what is the daily rate when you're doing debridement coatings and laceration repairs? Well, you would think you would get as many as you need to repair. No, on certain services, I know that the max is around 7. If you are doing, let's stick to cardiology for a second. Let's say that you are doing an ablation. So you're doing some kind of an ablation of a tachycardia or AFib area for a patient. Then the add-on codes and the MUEs for those ablations have an MUE of 3. So it's when they don't expect to see more, then you may report because they say now it's just out of control. So keep an eye on that list because it depends how many you report and it could come back to kick you and get a cert denial. So that's what an MUE is in case you didn't know. Okay, so for my personal tidbit this week, I am going to give you maybe a tip on stocking stuffers. So I'm known for my stockings. I love having unusual things in there, but things that people will actually use. Well, I know my daughter does not listen to my CodeCast podcast, so I can kind of share with you one thing I'm putting in her stocking. So she is a pickle-aholic. She loves pickles, and I got her on the Claussen bandwagon because they're the ones that are refrigerated. Everything else is just on a shelf. They're my favorite pickles too. But nobody wants anybody's fingers in the pickle juice and grabbing a pickle out of there. Let's face it, very few people will actually use a fork to get a pickle out. So there's something called a pickle claw. You can find it on Amazon for $9, and it's awesome. You push a button and it claws and it grabs a pickle and pulls it out. So that's one thing, and everybody can always use kitchen tweezers. Have you ever heard of those? So yeah, it's basically when you just need to, if you're decorating or you just need to grab something that maybe, this chocolate chip shouldn't fallen into this kind of cookie if you're making Christmas cookies. So there's Christmas tweezers now. So look at those. And then the last thing, look, again, I love Amazon, but look on there for your people who are gamers. So if they're sitting there on their console and playing video games, there's now gamer socks. Yes, it says, if you can read this, I am playing my game, so ignore me. But anyway, just a couple of stocking stuffer extraordinaires. And I've got, my stockings are pretty epic. And I wrap everything. You name it, I wrap it. So anyway, everyone, make it a great day, a great week. And thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.